The knee is a superficial joint. Interposed between the femur and the tibia, it is prone to injury. Because of the shape of the articulating surfaces, there is little inherent stability in the knee joint, and the ligamentous structures play an extremely important role in maintaining stability of the knee. Inspection. Both legs must be adequately exposed, and comparison between the knees should be made throughout the examination. During the gait cycle, the knee is maintained in slight flexion, except at the point of heel strike, when it is in full extension. With the patient standing and weight borne equally through both lower extremities, observe the angle between the femoral and the tibial axis. Normally, the tibia is in slight valgus with respect to the femur and is usually more pronounced in the female because of the wider pelvis than in the male. Excessive valgus or genu valgum gives rise to the knock-knee deformity, in which the medial aspect of the knees are in contact with each other while the medial malleoli are widely separated at the ankles. In varus deformities of the knees, or genu varum, the knees are separated, but the medial malleoli are in contact with each other. Genu varum is commonly associated with medial compartment osteoarthritis of the knee. Although the varus and valgus deformities illustrated are bilateral, they may be unilateral. Atrophy. While still observing the patient from in front, note the muscular contour above the thigh and knee. Specifically, note any atrophy of the vastus medialis, which may be associated with traumatic or degenerative knee pathology. Swelling. Note any enlargement of the knee as compared to the other knee. This may be due to localized swelling or generalized swelling about the knee, and the precise cause will be appreciated by the examiner when palpating the knee. Patella. Note that the patellae should be at the same level, and each pointing in a similar direction. Next, observe the patient from the side. The knee should be in full extension. In females and adolescents, occasionally slight hyperextension up to 5 degrees, also known as back kneeing or recravatum, is normal, providing that it is symmetrical. While standing behind the patient, observe the popliteal fossa region, noting in particular any swelling as compared to the other side. Palpation. Bony landmarks. Patella. With the patient in the supine position, palpate the patella. Its size and shape should be noted and compared to the opposite knee. The superior and inferior pole of the patella can be localized. By pressing the patella medially with the thumb, the undermedial surface can be palpated, noting any tenderness or irregularity, and likewise, with lateral pressure applied to its medial border, the lateral articular aspect can be palpated. With the patella displaced either medially or laterally, also palpate the anterior portion of the femoral condyle, which becomes uncovered. Tibial tubercle. With the knees now flexed to 90 degrees, locate the inferior pole of the patella. Palpating inferiorly along the course of the patellar tendon, the examiner encounters the tibial tubercle, which may be excessively tender and prominent in the adolescent with Osgood-Schlatter syndrome. Palpating upwards with the thumb along each side of the patellar tendon, the examiner notes a depression anteriorly. With firm pressure inwards and upwards, the examiner locates the medial and lateral femoral condyles respectively, and with pressure directed more inferiorly, the anterior margins of the medial and lateral tibial plateaus can be palpated. Medial tibial plateau. Localize the anterior border of the medial tibial plateau and follow its prominence around to the posteromedial corner of the knee to the point where its definition is lost in the soft tissues. Medial femoral condyle. Return to the anteromedial depression and palpate upwards, localizing the medial femoral condyle. Palpate the surface of the condyle superiorly towards the upper pole of the patella, noting any areas of tenderness or actual defects which might be palpable. Medially, palpate the edge of the condyle from its position above the medial tibial plateau, superiorly towards the upper pole of the patella. Carefully palpate the medial aspect of the medial femoral condyle and locate the prominent adductor tubercle posteriorly. Lateral tibial plateau. Locate the anterior depression just lateral to the patellar tendon, and inferiorly the examiner locates the anterior aspect of the lateral tibial plateau. Follow the upper aspect of the lateral tibia posteriorly and the prominence of Gerdy's tubercle. The site of insertion of the fascia lata is palpable. Head of the fibula. Continue to follow the lateral tibial plateau around posteriorly until a more lateral prominence is encountered. This is the head of the fibula, and its anterior and posterior border should be localized. Lateral femoral condyle. Return to the anterolateral soft tissue depression and palpating upwards, locate the lateral femoral condyle. Less of the articular surface of the lateral femoral condyle is palpable than the medial condyle because of the overlying lateral aspect of the patella. Palpation. Soft tissues. Because the knee joint is superficial, inflammatory or infectious conditions causing elevated temperature in the knee can be readily detected by the examiner. Slide the palm of the hand down the anterior thigh, over the knee and along the anterior aspect of the tibia. A change in temperature gradient, if present, will be readily noted by the examiner. Anterior aspect. With the patient supine, instruct the patient to isometrically contract the quadriceps muscle. Regions of the vastus medialis and vastus lateralis are noted, and palpate each region and compare to the opposite extremity, noting the consistency and firmness of the muscle mass. If there is weakness of the vastus medialis, the muscle will not feel as firm as compared to its opposite normal. Carefully palpate the tendinous insertion of the rectus femoris and vastus intermedius into the superior pole region of the patella, noting any tenderness or palpable defect. Patellar tendon. Locate the inferior pole of the patella and palpate the patellar tendon distally to the tibial tubercle. This tendon can be made more prominent by flexing the knee to 90 degrees and palpating the tendon between the thumb and index finger. Any tenderness, swelling, or defect should be noted. Swelling. Diffuse soft tissue swelling of the knee, secondary to contusion, can occur. Fluid about the knee may also be localized in one of the several bursae of the knee, or it may be intra-articular and manifested by a generalized enlargement of the knee, most notable in the suprapatellar pouch. Intra-articular fluid may collect posteriorly in the popliteal region and is termed a Baker's cyst. Localized swelling. Bursae. prepatellar, superficial infrapatellar, pes and serine. Prepatellar bursa. The prepatellar bursa is located anterior to the patella. Normally, the anterior bony surface of the patella is palpable directly underlying the skin. Any thickening or fluctuance anterior to the patella is suggestive of an inflammatory condition of the prepatellar bursa. Superficial infrapatellar bursa. Swelling in the region of the superficial infrapatellar bursa, which overlies the patellar tendon, can occur as a result of repetitive trauma, such as in kneeling activities. Pes and serine bursa. The pes and serine bursa is located deep to the insertion of the sartorius, gracilis, and semitendinosus muscles on the medial aspect of the upper tibia, and this region should be palpated, noting any swelling, thickening, or tenderness. Generalized swelling. Effusion hemarthrosis. Synovial thickening. Bony enlargement. Soft tissue swelling. Effusion hemarthrosis. Fluid within the knee joint is known as an effusion if it arises from synovial inflammation, and if it is secondary to bleeding within the knee joint, it is called a hemarthrosis. To test for fluid within the knee joint, the patient must be supine and the quadriceps muscle relaxed. Place one hand anteriorly over the knee so that the thumb and index finger straddle the patella. With the other hand just above the patella in the region of the suprapatellar pouch, press downwards. If fluid is present in the suprapatellar pouch, it will be squeezed inferiorly, and the fluid pulse imparted to the thumb and index finger will be appreciated by the examiner. By keeping the suprapatellar pouch obliterated, pressure applied by the fingers on the medial aspect will cause a fluid wave to be discerned by the examiner's thumb. Conversely, if pressure is applied to both the medial and the lateral aspects of the knee, while relaxing the pressure on the suprapatellar pouch region, the fluid wave can be appreciated by the examiner's hand as fluid is pushed back into the region of the suprapatellar pouch. Patellar tap or patellar ballottement. To perform the patellar tap or ballottement test, apply pressure to obliterate the suprapatellar pouch while the thumb and fingers palpate laterally and medially respectively. With the other hand, press the patella sharply downwards onto the femur and release. The patellar tap or patellar ballottement sign is not an absolute indication of an effusion. It is dependent on the patella being floated off the articular surface of the femur, which will not occur if the effusion is too small. In a moderate effusion, the patella will sink until it contacts the femur, then spring back up. The thumb and fingers of the hand obliterating the suprapatellar pouch will also detect a fluid wave. In a large tense effusion, the examiner will not be able to depress the patella against the femur without causing undue pain to the patient. Knee swelling may also be caused by synovial thickening. In this case, the examiner notes a boggy thickening, especially to palpation of the suprapatellar pouch region. Enlargement of bone or osteophytes, especially in the region of the femoral condyles, may also cause apparent swelling of the knee. Medial joint line and medial meniscus. With the patient sitting and the foot supported on the examiner's knee, the patient's knee is flexed to 90 degrees. Relocate the soft depression anterior and medial to the patellar tendon. Now locate the femoral condyle above, the tibial plateau below, and the medial joint line and peripheral attachment of the medial meniscus can be followed around to the posteromedial corner of the knee. It is extremely important to localize tenderness to either the femoral condyle above, the tibial margin below, or to the joint line, because not all tenderness on the medial aspect of the knee is indicative of a torn medial meniscus. Medial collateral ligament. The medial collateral ligament arises in the region of the femoral epicondyle, and the deep portion attaches to the meniscus and the edge of the tibial plateau, while the superficial portion courses downwards onto the flare of the tibia. The medial collateral ligament, which is part of the joint capsule, is not palpable as a distinct entity. However, its anatomic position, approximately midway from anterior to posterior on the medial aspect of the knee, should be palpated. Lateral joint line. With the patient still in the sitting position, re-identify the soft tissue depression just anterolateral to the patellar tendon. Noting the femoral condyle above and the edge of the lateral plateau below, the region of the lateral joint line can be followed around to the posterolateral corner of the knee. Lateral collateral ligament. Have the patient cross the leg over the other leg and flex the knee to 90 degrees. Allow the hip to abduct and externally rotate. Palpating posteriorly along the lateral joint line, the examiner can locate the cord-like lateral collateral ligament. Follow this structure proximally to its origin from the lateral femoral epicondyle and distally to its insertion on the fibular head. Common perineal nerve. With the patient sitting, support the foot and flex the knee to 90 degrees. Locate the head of the fibula. Posteriorly, at the neck of the fibula, the common perineal nerve can be located as it comes from posterior to anterior. Extreme caution must be exercised in palpating the common perineal nerve, since it is very sensitive to pressure and may be injured by an overzealous examination. Popliteal fossa. The patient lies prone and is instructed to flex the knee against resistance. This allows the examiner to readily identify the semitendinosus tendon medially and the biceps femoris tendon laterally, which outline the supromedial and the suprolateral confines of the popliteal fossa. The lower margins of the popliteal fossa are formed by the medial and lateral heads of the gastrocnemius muscle. Having identified the boundaries, relax the leg. Compare both popliteal fossae in order to detect any cyst-like swelling or the so-called Baker's cyst. With deeper pressure, the popliteal pulse can be identified in approximately the midline and may be more easily palpable while the patient is sitting with the knee flexed to 90 degrees. Range of motion, active and passive. Extension. With the patient sitting at the edge of the examining table, instruct the patient to straighten the knee and allow it to return to the relaxed position. Since the knee joint is superficial, it should be palpated during this extension-flexion motion, and the examiner may be able to detect crepitus arising from the knee joint. Compare extension to the other knee, noting any lack of full extension. If a patient is unable to fully extend the knee, but passively the knee can be brought into full extension by the examiner, then this represents an extensor lag, and is likely due to weakness of the quadriceps muscle. If, on the other hand, the examiner is unable to fully extend the knee passively, then this may represent either a flexion contracture, or if the resistance to extension feels springy, then a locked knee from an interposed torn meniscus is possible. Rotation. In the sitting position, instruct the patient to internally rotate the lower leg and externally rotate the lower leg. There is approximately 10 degrees of internal rotation and 10 degrees of external rotation of the tibia with the knee in the flexed position. This can be confirmed passively while palpating the tibial tubercle. Note that on achieving full extension, the tibial tubercle rotates laterally, and this is called the screw-home motion. Note that no further external or internal rotation of the tibia is possible with the knee in full extension. Flexion. With the patient lying supine, support both heels with one hand and raise the legs off the examining table. Note that the knees go into full extension, 0 degrees, or slight recurvatum. If the knees do not go into full extension, then the degree of lack of extension must be recorded, and the range of flexion is then determined by the difference between that amount and maximum flexion. Return the legs to the examining table and ask the patient to flex the knee as much as possible. First one leg, then the other. The normal amount of flexion is 135 degrees and should be measured with a goniometer. Note that in the younger normal patient, the heel should almost touch the buttocks, and a difference of flexion can be noted by a difference in the heel-buttock distance. Finally, with the patient completely relaxed in the supine position, passively flex and extend the knee while palpating the knee region. Note that the motion should be smooth and pain-free. Neurological examination. The neurological examination of the knee region is illustrated in the video program on the physical examination of the lumbar spine and neurological examination of the lower extremities, but would normally be carried out at this point in time in the physical examination of the knee. Special tests. Measurement of quadriceps atrophy. Special tests related to patella. Special tests related to meniscus. Special tests related to knee stability. Measurement of quadriceps atrophy. Following a significant injury to the knee, atrophy of the quadriceps muscle may be noted. Numerical documentation by the examiner is essential so that rehabilitation can be followed more accurately. Localize the anteromedial joint line bilaterally and mark a point 4 inches or 10 centimeters proximally. Measure and record the circumference of the thigh at this point. Do not measure from the superior pole of the patella, as this is not a fixed or a constant bony landmark. Special tests related to patella. Patellar apprehension sign. With the patient in the supine position and the quadriceps relaxed, the examiner applies pressure along the medial border of the patella, attempting to push the patella laterally while progressively flexing the knee. Observe the patient's face for any sign of distress, and also note any contraction of the quadriceps muscle which tends to relocate or centralize the patella. The patellar apprehension sign is a useful test when recurrent lateral subluxation or dislocation of the patella is suspected. Patellofemoral grind test. This test is described primarily so that the examiner will not use it. The patient is supine with the legs relaxed. Distal pressure is applied to the proximal pole of the patella using the thumb and index finger. The patient is then instructed to contract the quadriceps muscle, and the report of pain by the patient is said to be indicative of pathology in the articular surfaces of the patella and femur. I find that the patellofemoral grind test is frequently positive in normal individuals, and also it can cause extreme pain, and the examiner will lose the cooperation of the patient. With the knee relaxed, I find that gentle pressure applied to the anterior aspect of the patella while attempting to move the patella back and forth, or medially and laterally, as well as proximally and distally, will allow crepitus to be palpated if significant articular pathology is present. This is much less distressing for the patient than the formal patellofemoral grind test. Special tests related to meniscus. McMurray test. The McMurray test is a useful adjunct to the diagnosis of a longitudinal tear or a flap tear of the posterior part of a semilunar cartilage. To test the medial meniscus, the patient lies supine, and by grasping the heel with one hand, the leg is fully flexed at the knee. The other hand is placed over the knee so that the fingers are along the posteromedial joint line and the thumb along the posterolateral joint line. Internally and externally rotate the leg in the fully flexed position. End with external rotation and apply a valgus stress to the lower leg while slowly extending the knee. The production of a click or snap, which is palpable along the medial joint line and may also be audible, is usually sensed by the patient with associated pain and indicates a positive McMurray's test. The examiner is cautioned that clicks arising from sites other than a tear of the posterior meniscus may be elicited. But the McMurray click, although specific in character and localization, is only one sign of posterior meniscal pathology. Testing for the posterolateral meniscus is done in a similar manner, but this time the leg is maintained internally rotated and a varus stress applied. Apley compression and distraction test. Compression test. The patient lies prone on the examining table and the knee is flexed to 90 degrees. Stabilize the patient's thigh by applying light pressure posteriorly with your lower leg. While pressing downwards on the heel, rotate the tibia internally and externally. Complaints of pain and its localization, either medially or laterally, implicate meniscal pathology, as the meniscus is ground between the femur and the tibia during rotation. Distraction test. Maintaining the same position, now distract the knee by pulling upwards on the foot and heel. Again, internally and externally rotate the tibia, and any pain produced should be localized by the patient. In the distraction test, the collateral ligaments, capsule, and coronary ligaments are being stretched, and a positive test would indicate pathology in these structures rather than the meniscus. Special tests related to knee stability. As mentioned in the introduction to this program, the knee does not have an inherently stable bony architecture and relies upon the ligaments and capsule for stability. The tests for the integrity of the collateral ligaments and the anterior and posterior cruciate ligament will be discussed. Collateral ligaments. Medial. With the patient in the supine position, allow the thigh to remain on the examining table to assist patient relaxation. Abduct the leg and stabilize the lower leg between the examiner's arm and body to allow both hands to be free. Apply one hand to the lateral aspect of the knee and with the other hand palpate the medial joint line. A valgus stress is then applied to the knee, initially in full extension and then in approximately 30 degrees of flexion, while palpating the medial joint line to detect any opening or separation of the upper tibial margin from the distal femur. Medial opening of the knee in extension, as well as flexion, implies a more significant instability and consequently more structural damage than does opening in flexion alone. Lateral. To test for lateral instability, adopt the same position as for testing medial stability, but this time the fulcrum is placed on the medial aspect of the knee, and with the other hand palpate the lateral joint line. Apply a varus stress to the knee, both in full extension and also in 30 degrees of flexion. Again, instability demonstrated in full extension implies more structural damage on the lateral side than does instability which is only present at 30 degrees of flexion. Stress views can confirm the diagnosis, and if patient relaxation is not possible because of pain, the use of local, regional, or general anesthesia may be indicated. The examiner is reminded that for any ligament test, comparison must be made with the opposite knee. Anterior cruciate ligament. The primary restraint to anterior displacement of the tibia on the femur is the anterior cruciate ligament. Anterior drawer test. The anterior drawer test is performed with the patient supine and the knees flexed to 90 degrees and the feet flat on the examining table. Stabilize the foot by gently sitting on it and cup both hands around the back of the upper tibia while the thumbs palpate the anteromedial and anterolateral joint lines. Assure the hamstrings are not contracting by palpation posteriorly. Attempt to draw the tibia forward from under the femur, which would signify a positive test. Compare with the other knee. Lockman test. In acute injuries to the anterior cruciate ligament, the drawer test may be negative because the secondary restraints to forward displacement of the tibia remain intact. Also, pain, hamstring spasm, and a tense hemarthrosis may negate the anterior drawer test done with the knee flexed to 90 degrees. The Lockman test has been shown to be more accurate in the diagnosis of acute anterior cruciate injuries. In the Lockman test, the upper tibia and lower femur are grasped by the examiner's hands while the knee is held in approximately 10 degrees of flexion. Forward sliding of the tibia in response to a forward pull on the tibia indicates a positive Lockman test and is diagnostic of an anterior cruciate ligament injury. There is also a lack of a definite endpoint in contrast to the sharp definite endpoint in a negative test or when the anterior cruciate remains intact. Pivot shift test. With chronic tears of the anterior cruciate ligament, the secondary restraints become lax and an anterolateral instability becomes manifest. In full extension, the anterolateral aspect of the tibia subluxes forward from under the femoral condyle and reduces during flexion. To demonstrate this phenomenon clinically, the patient lies supine and the leg is elevated by grasping the tibia above the ankle. Internally rotate the tibia and apply an anterovalgus force over the upper lateral aspect of the lower leg. Passively flex the knee and at approximately 30 to 40 degrees, the tibia will appear to jump posteriorly into its reduced position. Likewise, progressing from a flexed position, the tibia will appear to jump anteriorly as full extension is approached. Posterior cruciate ligament. Posterior sag sign. With the patient lying supine and the knees flexed to 90 degrees, observe from the side. If the posterior cruciate is torn, the tibia on the affected side will sag posteriorly, and the tibial tubercle will be less prominent. This posterior sag may also be noted with the patient lying supine and both hips and knees flexed passively to 90 degrees. Posterior drawer test. This test is performed in a similar manner to the anterior drawer test, but in this case, posterior pressure is applied to the upper tibia, and in the presence of a posterior cruciate ligament tear, the tibia will be observed and felt to displace backwards. The drawer tests are normally performed at the same time, but it is essential to first look for a posterior sag. If the tibia is already displaced backwards, then performing the anterior drawer test will merely reduce the posterior sublux tibia to its normal position, and this does not indicate a torn anterior cruciate ligament. This concludes the examination of the knee. The examiner is reminded that symptomatology reported about the knee, especially in children, may in fact be referred from pathology about the hip, and a thorough examination of the lumbar spine, hip, foot, and ankle must be carried out.